Thank you, everybody, and thank you for asking me to speak today. It's quite the honor. And I was really excited that the C. difficile conversation was going to take place right before lunch, so that's something really exciting. So the only disclosure I have is that my husband works for Zoetis, which is a healthcare company, but they make animal healthcare products, so I don't think we're going to talk about any of that today, but that is there, so just so you know. Objectives, we're going to discuss how to develop a decision tree for doing C. difficile testing, and then we're going to kind of outline some of the general guidelines for doing a drill down form, so when you're reviewing cases, you don't miss anything and you're catching all of your important points when you're trying to look at a hospital-acquired case and your improvement opportunities. So where's your focus when you're looking at improving your C. difficile rates and your risk for C. difficile? There are so many things we're looking at now, and there's so many things that nurses do and that staff do on the floor that when they're taking care of patients. They're care planning, they're doing med reconciliation, they do education, they do family support, they do assessments, they do treatments. I mean, we could just keep going page after page after page. And so there's just lots of things that consume their time. So you get to the point where you feel like you're juggling balls all the time, all day long. And is there anybody in here that actually knows how to juggle? I mean, in all seriousness, I tried to teach myself how to juggle because I thought this was the greatest example of, you're throwing 3 balls up in the air, and what happens if you take your eye off of one of those balls for just 1 second? The ball ends up probably falling on the floor. It's going to fall on the floor. And if you look at each one of these balls here that I have listed, every one of them has multiple components that nursing staff and other staff and physicians are looking at every single day and every single shift to make sure your patients don't get sick. CAUTI prevention, you're looking at your Foley every 2 hours. Is the bag on the floor? Does it have dependent loops? Is the seal intact? You're looking at CLABSI prevention. Did we put the line in? Did we use maximum barrier protection? Did we change the dressing this week? Did we change the tubing in the caps? Skin and pressure wound management. What does the wound look like? What are we using for creams? What are we using for dressings? Did we offload? What kind of bed do we have? I mean, there are multiple things for every patient every day that we're looking at, and that's for one patient. So how many patients are we taking care of? In critical care, they're taking care of 1 or 2, maybe 3 patients if they're not, on vents and 14 drips. In step-down units, they're taking probably 3 or 4 patients, and on the general care floor, they could take up to 6 or 7 patients. You're looking at all of those things every single day on every one of those patients. So what's going to happen when you take your eye off the ball of one of those things for 1 minute? Well, probably something's going to fall. And then what's going to fall and how many things are going to fall. So the patient's going to get a CAUTI, they're going to get a central line infection, they're going to get a pressure wound. How do you keep yourself organized and keep your staff organized and help them so that they know what to do, what to ask for, how to make good decisions on the floor, and how do you make it so that you can impact your patient outcomes? Well, what we did is we started out by repetition, on the floor all the time. And those people that are IPs, you probably all know, it's just that diligence. You're there all the time. You're on the floor talking to your staff. You're open to conversations. You're talking to them. You're doing education. We were unsuccessful doing that. Our rates kept going up and kept going up and kept going up for C. diff. We tried education. We tried de-escalating antibiotics when patients moved out of critical care. We have an antimicrobial stewardship pharmacist. They look at antibiotic usage all the time. We just could not get anywhere. So we thought, well, let's develop a tool for how to determine when we test. One of the things in kind of evaluating each case was we were doing a lot of inappropriate testing. And so maybe we need a tool to help the nurses figure out when do we need to ask for a test. So we decided, let's develop a tool. Let's see if we can develop something that the nursing staff on the floor can use easily to help guide them on when they need to when they need to ask the physician or call the physician for a test for C. diff. So how do you develop it? How do you develop a tool like that? Well, first of all, don't reinvent the wheel, of course. There's lots of great tools out there and lots of things you can get information from. So there's the Bristol Stool Scale, which we use. The CDC has C. diff guidelines and prevention resources. They're a great resource for everything, of course. There's actually a C. diff foundation out there, which is kind of cool. I went on there and looked, and they have some really cool things on there. And then there's the IDSA guidelines, which we use extensively. So, and these are in no order. I just put them in alphabetical order for ease. So. But we looked at all of these things and tried to determine and tried to make a useful tool that the staff could use. And we're on, I think, our second or third revision, because as we keep doing it, we keep realizing that, you know, something might change a little bit, or we want to tweak something, or staff is thinking this when we actually meant this. When you look at like the Bristol Stool Scale, some staff was thinking, well, maybe we should send a stool when you're type 6, because the lab test for C. diff, if the stool conforms to the shape of the container, that's their guideline. Well, it's type 6, which says it is mixed. I can't read it from here, but it will form to the shape of the container. Well, we kind of really don't want to send type 6. Most of the time, those patients, we really aren't going to have C. diff. We really want to send type 7. So anyway, so here's our entire C. diff decision tree in its entirety. So that's what it looks like. And we'll look here at kind of a breakdown a little bit. So we started at the beginning and we defined appropriate testing. So what do you define as appropriate testing? So for us, appropriate testing was when the patient had greater than 3 watery stools in a 24-hour period. And that meant it wasn't normal stool for the patient. So does the patient normally have watery stools? You know, do they have IBS? Do they have something that causes them to have watery stools sometimes? So that was our decision of what appropriate testing was. And then we look at what are your clinical symptoms and findings. So if they have less than 3 stools in 24 hours, we don't want them to send a stool sample. Are they on laxatives or are they on tube feeding? No, we really don't want them to send a sample then either. We had an issue with laxatives because we had an order on our sepsis order set for C. diff testing if the patient had diarrhea, with no stop on the order. So the patient would admit, they'd be in critical care, they'd be on the vent, they'd have all the pressors running, they'd be running along, they'd be getting better, they'd be extubated, they'd get all their meds off. They would get to the point where they're awake and they're doing things, and they hadn't had a BM for 4 days because they'd been on the vent and all these other things. And so they'd start giving them laxatives, and so they give them a day or two of laxatives and a stool softener and a fleet. Then they'd start going, then they'd have diarrhea for a couple days, and then they'd want to send a stool for C. diff. Don't send a stool for C. diff after you've given laxatives for 3 days. Probably they're having diarrhea because you've given them laxatives for 3 days. So that was one issue. So we took that order off the order set. So there's one thing. Don't put automatic orders on your order sets. That's probably not a good idea. That we got rid of that one. So that was an early find for us. And then tube feeding is the same way. You know, you have patients in critical care, and they start tube feedings if they're going to be ventilated for for over a certain amount of time, and then they start tweaking those tube feedings. Well, as they're going up on tube feedings, sometimes the patients will have diarrhea, so you want to watch that and you want to look at that before you automatically just order a C. diff test because the patient's having a little bit of diarrhea. So, and then one of the other things is the patient having symptoms? Are they nauseated? Are they having abdominal cramping? Are they having a fever? Are they having any blood or pus in the stool? If they're not having any symptoms and they're just having a little bit of diarrhea, why are we sending a C. diff on a patient that's not having any other symptoms? Because most likely if they're having a C. difficile infection that they need PO Vanco for, they're probably going to have some symptoms with it. They're going to have some abdominal cramping with it. They're going to have some abdominal discomfort with it. So if they're not having any of those things, let's wait and see what happens. And some nurses would be like, I got to send it before I leave today. No, let's wait and see what happens over the course of the day. And some patients, yes, they might develop abdominal pain later in the day, and then they can send one then. But let's assess that a little bit more instead of just automatically jumping on it. And then the next one is the stool pattern typical for the patient. And that's where you really have to talk to your patient. Does the patient normally have diarrhea easily? You know, a lot of people have bowel issues now. They have IBS, they have Crohn's, they have a lot of other issues with their bowels. So that's where the history part comes in. And then have they been diagnosed with C. diff in the last 4 weeks? We really don't advocate for retesting patients within 4 weeks unless they really are becoming symptomatic and they're spiking temps, they're getting abdominal cramping and pain, and they're saying this is just like it was last time, I feel like I'm really getting sick again, then the doctor might want to go ahead. But that's a conversation you need to have with the physician and the patient about their symptoms, not just automatically saying, can I get a C. diff order? So. And then the last thing is checking to see if they had a recent negative C. diff, because we only test our patients for C. diff once in a course of like 7 days. So if we've already tested them, we don't retest them every day. So it's not like, oh, we tested them yesterday, let's send another one today. We don't do that. So don't bother sending it because the lab's not going to run it. So it's a waste of time, and don't do it. So this is kind of where we're at now with our decision tree, and this is how we do it now. It's looked different than this also over time. We've tried to make it a little bit easier to read for the staff so that it's easier to flow for them. By the time you get the positive test result back, you have now exposed a lot of people to C. diff, because there have been people in and out of the room, and the patient's been to therapy, and they've been in the hall, and they've been, don't do that. Get them in isolation right away. So. And then once you're done and you get your decision tree ready and you get it educated out, you do need to reinforce it frequently. Don't be afraid to educate on individual components and be the squeaky wheel. Once we got this done, we have what we call the required clinical reading, and so every week it goes out on Friday, and all the clinical staff is supposed to read any updates or anything new and that kind of stuff on it. And so every couple of weeks, I would take one little part of the decision tree and send something new out on it. Don't forget on this to blah, 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 or I'd put a picture or something different on it, or I'd put some more information, add something to it, maybe state it a different way. Do something so you've always got it in front of the staff so that they're seeing it they're seeing it again and again and again and again. It's that repetition of seeing it over and over, I think, that really helps a lot. One of the other things with doing it that way is they get used to seeing it, and then it becomes part in their head that it's just natural then when they're taking care of their patient. It comes up, it's a quick reminder, and they remember it a lot easier. So. Of course, on this too, they also want to be looking at what antibiotics they're on. That is not necessarily a part of our decision tree, because that's a part of our review process, which we'll go over here in a minute. But you definitely want to make sure that you're going to look at that once you review if your patient does get C. diff. So that's kind of how we did our decision tree, and how I continue to educate out on it. It seems to have worked for us, and I'll kind of show you where our rates when we get down to the end here, and you can see kind of where we're at, where we were, and where we landed. Because although Dr. V's hospital was at 0.3, we were not at 0.3. We were way higher than that. So once you have a patient who has C. diff, what do you do about it, and how do you take that patient, really look into it in depth and learn something from it so that you can take that information back to your staff and actually give them some information so they can improve their care, so we can hopefully prevent patients from getting it again. And then once again, don't recreate the wheel. There are a lot of resources and a lot of review tools out there for reviewing patients. You can do a full RCA, which is a little dramatic for a hospital-acquired C. diff, but some places do that. They have just culture, safety first. You can do a Google search. There's all different kinds of things that you can do and different options that are out there. And if you just just Google, C. diff review sheet, you can, and do images, there's like a gazillion of them you can see. Don't be afraid to make it a useful form, because if you fill out a form and it's not useful and you don't use it for anything, it's a useless document. So make it your own, make it work for what you want it for. There's several different options. You can use Excel, you can use a Word document, there's OneNote, you can use pen and paper. And if you're a smaller hospital and pen and paper works and you start a form and you pass it to the next person and they fill in their part, if it works for you, then use it. You want something that's going to work for you, that you're going to be able to evaluate your incident and get some useful information from it. This is what we started with. It was very simple. We just had the basic patient demographics at the top, the patient's initials, your basic information. If they'd been on antibiotics, what we were treating their C. diff with, if they'd been on GI meds, just kind of general GI meds, when their culture date was, if they, when they started having diarrhea, when we initiated isolation, and then if they moved if they moved in the hospital, so if they bed traced, so if they went from one unit to the next. So started out super simple. We have went from that to, this is my 5th edition now that I keep revising because I keep deciding I want things in a different place and I like the way it flows better. But we actually have a CDI prevention team, and that includes one of our hospitalists, our antimicrobial stewardship pharmacist, our quality director, myself, our EVS director, our nursing director. And then what we do when we have a hospital-acquired case is we meet on the unit with the director and the clinical educator for that unit, and then we pull any of the staff that's available to come in also, and we talk with them. So we look extensively at what antibiotics they were on. We look at stop and start dates. We look at which antibiotics they were. We look at why they were on them. The antimicrobial stewardship pharmacist looks at what they were on them for, if they were appropriately indicated. If they were not indicated, then she takes that information back to the prescriber and gives them some feedback. We had a patient that was on something, I can't even remember now what they were on, for Pseudomonas, and it wasn't even effective against Pseudomonas. And so it was like she took that back to the provider, and it happened to be one of the hospitalists. So it's great to have their expertise, because they're able to take that information back and give that back to the provider so that they can improve their care also. So we look at the GI meds more intensively. We look at if they're on proton pump inhibitors or H2 blockers. We also look then, of course, at the laxative use, like I talked about with the other. We look at the culture date, when we started isolation, and making sure that they had switched to bleach wipes in the room instead of just regular wipes. Our EVS staff always follow what the caddy says in the doorway. So as soon as the caddy goes up and they have up that the patient's in, we call it modified contact isolation, and it has a brown sign, then they know that means they have to use bleach wipes in the room. And then everybody has to wear gown and gloves, and then it's always hand washing coming out of the room, and they always use bleach wipes in the room. So that's the key to everybody, that's when that switch happens. So, and then if the patient moves rooms, that caddy stays at the door. They put a new caddy at the new patient door, and then the EVS people know that that's what was going on in that room, so that they clean it appropriately, and they know to take the appropriate precautions and the appropriate PPE when they're cleaning the room. So this is the last part of the drill down sheet that we're using, or the first part of it, in a little bit closer detail so you can see it a little bit easier. But this is, the top is the same as the other. It has the patient's demographic, and then the information about the antibiotics. And then we look a little bit more intensively also at patient symptomology now. If they're having abdominal pain, if they're having elevated white count, fever, and then of course the PPI use. Other GI meds, so we're also looking to see what other GI meds are on besides laxatives, to see if they're on stool softeners, if they're on anything else. Then, of course, the tube feedings, and we do look at IV contrast too, because sometimes that can cause a little diarrhea that can mimic an issue if you're not careful. So. And then the next section is kind of the infection section that I usually focus in on and try to fill out, and then the EVS section. Then we have a little section at the bottom where we put our review conference notes, and then our opportunities and recommendations, and then that can go out to staff and can go out as a learning tool, and then that's what we use with staff to educate. Those are the things we use to educate on. Our education always goes back to the staff for the unit that was involved directly, and then more kind of general education for all the staff, just kind of in general, don't forget to do blah, blah, blah if there was something that was missed, if there was an opportunity. So doing all of that and focusing on it for several months, we went from a rate of 2.85, which was extremely high, to we're now down to, we were as low as 0.387, and we're up down to like 0.8. So, but we made a huge improvement, but it took a whole group of people to do that. All of those people that are on the committee put in a lot of time, and we meet monthly on it, and we look at every single hospital-acquired case so that we can try to make better choices so that we have better patient outcomes. And I think probably the biggest things to take away from this is to don't recreate wheels, ask for help. If you're in a facility and you're by yourself and you're trying to develop something and you can't find anything, call someone. At all of the hospitals, there's IPs that are always willing to help, and if they can't answer your question, they will always know who you can call to ask. And so all across the state, there's people that will help you if you need help with developing any type of drill down, or if you have questions about anything, regardless if you're at a critical access hospital or if you're at a extended care facility, regardless of where you're at. If you're a new person that is just getting into doing infection control, and if you're whatever you're doing, ask if you need help with it, because there's lots of people in this state, and we can help improve our state's population and our healthcare in our state, and that would be a great thing. So, does anybody have any questions? Hopefully I got you done early.